to understand diabetic retinopathy, you need to have a very basic understanding of basically what the retina is. I find one of the struggles with nursing school is it's a lot of information to retain, and between anatomy and by the time you take patho and what have you, it's totally reasonable that you forget some of this stuff. So I always like kind of do a little review ahead for myself, which is why I spend all of my time studying and my kids wonder where I am. But anyway, so let's talk about the retina a little bit, just a little bit. This little kind of thing is great. The retina is a thin layer of light-sensitive nerve tissue that lines the back of the eye or the vitreous cavity. When the light enters the eye, it passes through the iris to the retina where images are focused and converted to electric impulses that are carried back to the optic nerve to the brain, resulting in sight. Perfect. Now we understand basically what this thing is that we're about to talk about. And the only other thing is that it will talk a lot about the macula as well. The macula is just basically this, oh, it's good, it's on here, this little kind of center thing here that it's like the functional center of the retina. So when the light comes in through the lens, it's hitting this macula here, and that's what's giving us the vision, like the 20/20 vision and best color vision and all of those things. So the retina basically allows the light in, and so that the lens can then focus that light, and we can make sense of it through the impulses that are then carried to the brain through the optic nerve. Okay, so no problem, we got that. Retinopathy, diabetic retinopathy, very, very common in type 1. Almost every single that's amazing, like almost 100% people with diabetes, diabetic type 1 will end up at some time with diabetic retinopathy. It's fairly common in type 2 as well, about 60%. Basically, there's a few little like kind of different things that are going on or that are happening. I'll try to take you through it. So there's some vascular permeability that's happening that's abnormal, right? You have these little microaneurysms that are forming. If you look like, right, it's there has to be blood vessels bringing all of these things, blood and nutrients and what have you, and so they can have these kind of little aneurysms that are forming. And again, all of these are the results of these things that we talked about in the last video, these theories as to why all of this microvascular damage is happening during diabetes. Why all these complications are happening. And so here, we're not going to go too deep into why that's happening, but just kind of give you a list of what's happening. Neovascularization, break it down, new blood vessels, right? Hemorrhaging, scarring, retinal detachment can actually occur. There's damage to the blood vessels. There's red blood cell platelet aggregation, vasoconstriction, influence of endothelial growth factors, hormones, angiogenesis. Honestly, guys, I wouldn't go crazy memorizing all of this either. I do think it's important to understand the difference between there's this proliferative retinopathy, and there's up here we have non-proliferative. So let's just go through really quick. Proliferative retinopathy is the more severe form. It's a full occlusion of the retinal capillaries, right? So these capillaries are bringing blood, obviously blood, oxygen, glucose, what have you, to the actually retina so that it can perform cellular respiration and have energy to do what it needs to do. When this occlusion happens, there are new capillaries, so there's all like that collateral circulation, right? There's neovascularization, but these new capillaries are very, very weak. They hemorrhage really, really easily, and they cause a contracted vitreous. And so if you look, there's one picture here of it. If you right here, kind of gives you an idea of if you look at this. I don't know if there's a normal eye here, but it's kind of pulling that vitreous area away from the wall, right? And so as a contraction, it's contracting in, and then eventually it can cause like a full detachment from the optic nerve. That's a major problem. If this is happening during this contraction, you lose that macula, remember that back point, that's it, you've lost your vision. And without treatment, over 50% of patients with proliferative retinopathy will go blind. What are the risk factors? Poor glycemic control, hypertension, hyperlipidemia, and again, Indigenous Canadians. These are all things we've talked about before, so that's good. We don't have to kind of go through them again. Non-proliferative retinopathy, on the other hand, this one is less severe, but it's much more common. It's a partial occlusion, whereas the other was a full occlusion, right, of these small vessels, which leads to these little microaneurysms in the capillary walls, which again weakens the wall. But then you have this fluid leakage, this kind of slow fluid leakage out of the wall, and that causes edema. And again, if your macula is involved in this, your vision may be affected. Now, I know that this looks, it looks more complicated than that, but there isn't a whole lot more that we need to focus on or memorize for when we're talking about diabetic retinopathy. It's the knowledge that having diabetes type 2 puts you at a very, very, very high risk of developing problems with your eyesight, and that blindness is common. That it's really just knowing that kind of stuff. It's not necessarily about going in and memorizing all of this. I do think it's important to kind of go over the difference between the proliferative, but we've kind of done that, and there isn't a whole, this one, proliferative, we're talking about full occlusion with revascularization or neovascularization or collateral circulation that hemorrhages really easily and causes detachment. Over here with the non-proliferative, we're talking about a partial occlusion that basically ends up with these little microaneurysms that weaken the walls, and you have retinal fluid that leaks through, causing edema. Those are like your main kind of, and you can kind of walk yourself through that to answer it for a question. There really isn't anything more we need to worry about for our purposes.